So it is my distinct pleasure to introduce my collaborator, partner, and friend, Robert Indian. We've worked together. I came to Ohio in 1996. I've had the pleasure to know him since then, and he has a breadth of knowledge of all things related to cancer, but also has been knee-deep in our 5-year cancer plan for the last 4 years as we move forward. So we're going to kind of, and Robert, come on up here so you can, so welcome, Robert. And how we're going to do this is, you can tell we're great collaborators because we see eye to eye because we're both about 5'6". So if we, if I
vertically challenged.
That's right. So if I stand behind that podium, you'll never see me again. So we're going to stand right up here, and I think we'll work from here if that's okay with you. And Vanna, you ready to move my slides? Okay. So I have the pleasure of being the East Central Division, being Ohio and Pennsylvania, working both on the executive committee of the Ohio Partners for Cancer Control and the PASLT. So thanks for the invitation from the Pennsylvania Department of Health for us to kind of talk about what where we are in our plan. This is not a how-to presentation. That's why we called it Lessons Learned. We're in year 4 of a year 5 plan. We are in year 1 here. So we've certainly got some bumps, and as Robert says all along, you know, we've got the bumps to prove where we've gotten to at this point. So we are not espousing that we did it perfectly, because we would be lying to you. So we're not going to do that. So I'm going to go through a little bit of background about the Ohio Partners of Cancer Control, and we really want to swiftly get into the lessons learned, and that's going to be the meat of you all, hopefully picking Robert's brain and talking about some of the things that we've come across. So the first slide there shows the Ohio Partners of Cancer Control. We were formed in the year 2000. We are a statewide consortium, much like you are here. We are representative of all corners of the state of Ohio and have lots of representation from many cancer-fighting organizations around the state of Ohio. We are not a 501c3 organization. We are just the Ohio Partners for Cancer Control. So this is what we look like. Our structure: we have a general membership, an executive committee, and a subcommittee. The subcommittees at this point, although they have been somewhat fluid throughout the 5 years of the plan, are treatment, survivorship, palliative care as one subcommittee. We have data and surveillance, prevention, early detection, and advocacy communication. So that's kind of what we look like. Any comments on that, Robert, before we move forward?
No.
Okay. Good. So the plan was from 2011 to 2014. It is, as our Pennsylvania plan is a strategic plan to reduce the cancer burden in Ohio. And it is designed to provide guidance to multiple stakeholders across the cancer continuum. So it includes cancer surveillance, prevention, early detection, quality of life, palliative care. It goes from the entire cancer continuum. So there's it is quite a document. It is not 5,000 pages, but it does have a lot in it. So,
John, if I could just add,
absolutely.
While this goes through 2011 through 2014, we actually released it in April of 2012. And we had been writing it since 2011. And we had some great achievements, and we did not want to leave those behind. We wanted to get credit for them. So we went backwards a little bit and went 2011 through 2014. So celebrate your achievements, certainly.
Yeah. And, you know, we started a couple of things about the plan is, we wanted to make sure that things were specific, measurable objectives, and that, you know, at the end of which we're doing now is in the final evaluation of the plan, that we had something to evaluate. So we do have specific, measurable objectives, and hopefully we do have a connection with our friends at chronic disease and some other areas, and hopefully some of the things that we're doing in the cancer plan will benefit them as well. And we did not want this to be a doorstop or something that when you opened it up you had to sneeze or take your Claritin from the dust on it. So we, you know, it is meant to be a dynamic document. Over the span of the last couple of years, we've added, and folks have come to us with new ideas, and we have added some objectives to the plan to ensure that it is a dynamic document. We have three guiding, next please, thank you. 3 guiding principles that cut across all. We have 14 goals and related objectives to it. Each of the guiding principles of the goals and objectives, they needed to be have data-driven decisions, be evidence-based interventions, and identification of disparities and progress towards equity. Next slide, please. So right now where we're at is we have evaluation of the comprehensive cancer plan that the Centers for Disease Control requires. It's got 3 parts. It's the planning part, the program part, and the partnership part. Next slide. The draft for the plan was completed and submitted to CDC February of 2014, and it established the evaluation parameters, the methodology, and the utilization plans of what the evaluation was going to look like. This was a great idea, I thought, and it also created an evaluation advisory committee on, or subcommittee or work group, I forget what we called it, within the Ohio Partners of Cancer Control. So there is a group that's working with the evaluator specifically from OPCC. And this is what they're asking. How much progress has been made? What factors have influenced the progress? To what degree does each aspect match CDC priorities? And how well integrated are the plan, the program, and the partnership? Next slide. It focuses on the goals and objectives rather than strategies. We are pleased to say that preliminarily that the evaluation has showed that there has been a lot of progress been made, but like most plans, we didn't hit the mark on every single objective. And part of this evaluation is, and it seems like yesterday we started, was it really 2011?
Just yesterday.
I was 6'5" when we started this, but
with dark brown curly hair.
With dark brown curly hair. We're starting, the ball's rolling again. So our new plan will be 2015, and we're just going to be exactly where we were here in Pennsylvania just a little while ago. So it would make no sense at all to evaluate the plan without looking forward. So that's kind of where we are with this plan. So next slide. So as far as the evaluation of the OCC program itself, it's, the OCC program and ODH is the conduit between the Ohio Partners of Cancer Control and the CDC. It does follow an annual action plan. That's Robert and his team's plan. I'm happy to say that his team has done an excellent job, and they're going to, they completed all the action items on their plan. And the next plan will focus on, guess what? Writing the next plan. So that's going to be Robert and his team's work for some time. So the next phase was the evaluation of the partnership. And that's just ongoing now, so I don't have any information to share with you about that. But basically, it will include factors such as the strength of partnership, representation, the level of engagement within the members, and in what ways is OPCC helping to carry out the plan. They're using a tool, is it Wilder Research, I believe, tool that is specifically designed to evaluate collaborations, and so we're looking forward to seeing how, from stakeholder perspective, how we're doing with how we're playing in the sandbox with each other. So a little shout out to a movie that was actually filmed in Cleveland, Robert's hometown. One of the practical lessons learned, hopefully as you were growing up, you learned them. Do not stick your tongue on a metal pole or bad things will happen. Anyway, next slide, please. So I know Robert's got some, and we've got 3 or 4 of these lessons learned types of things, but one of the major things that we tried to do, because we had limited resources, was to already build on the great things that were going on within the state of Ohio in cancer prevention and early detection. So we made a conscious decision to actually incorporate goals of other organizations into the cancer plan, so that and that helped in a number of ways. As an example, the colorectal cancer goals are very similar to the colorectal cancer goals of the American Cancer Society, and so we were that in essence allowed us to have an owner for each of the objectives within the plan. And I know So if you want to talk a little bit more about that.
Definitely.
Yeah.
Just a couple of things with an introduction from me. I was new to this program. I've been with the program for going on 5 years now. I came out of surveillance and epidemiology. I'm an epidemiologist by education and vocation. But I learned 3 very important words in epidemiology. What causes this? And that can be used for lots of different domains, different venues. There's not a day that goes by I don't ask, why are we doing this? Why are we doing this? Why are we doing this? What causes this? You know, why do people in the 21st century continue to light up cigarettes? You know, why don't people get screened? You know, what do you think this thing is hanging from your face? Why don't you go see a doctor about it? I mean, you know, sometimes it just, you know, the human behavior just absolutely boggles my mind. But you have to go to where the people are. And our approach in writing this plan was what already exists. But one of the things we insisted on, it took us 18 months to write this plan. And we released it in April 2012. What took 18 months? And that's because we insisted from the very beginning. Now, as you know, bureaucracies are notorious for writing plans. That's what we do best. And then they disappear in the file cabinets or on a shelf, and nobody thinks about it until it's due. Oh my gosh, we got to evaluate that plan. You know, so let's see what we got done by accident. Okay? Sometimes not even deliberate. This plan is different. Each objective has ownership. We had a very simple philosophy. If it doesn't have ownership, it goes in the plan. If it goes in the plan, it must have ownership. So we have responsible parties. Now, Ohio's got 2 comprehensive cancer centers, one at Case Western University Hospitals in Cleveland, the other at The Ohio State University in Columbus. They are actively engaged. But we wanted to make sure that each objective had ownership. I cannot overemphasize that. When it was done, we released it at a press conference at the State House with the Ohio Legislative Cancer Caucus. The Cancer Caucus is chaired bicamerally in Ohio. A person from the House and a person from the Senate chairs the Cancer Caucus. They worked with us. They came to our meetings. They could see the process in motion. When we released it, we had a press release. They made their remarks, and then we shared the plan with the news media. Very nice success story. But also, we wanted to make sure, the other philosophy that we have adopted is that when you come to a meeting, and we articulate this at the beginning of every meeting, you come from Cleveland, you come from Toledo, you come from Akron, you come from Youngstown, Cincinnati, Dayton, Portsmouth. We want to make sure you're glad you came. Everybody's got a boss. And all of you are going to go back someplace today, and your boss is going to ask you, was it worth it? And we want to make sure when you come to our meeting that you can say yes, and here's why. Now, if you can't do that, then something's wrong with the agenda. And it's not being reflective of the people that you want to participate. I never hesitate to say our best friend in cancer prevention and control in Ohio is the American Cancer Society. And we try to walk the talk.
Well, thank you.
And so it's an honor to be here with you folks. I really am honored. So, you know, treat them like your friends and colleagues, but make them glad they came. Have a role. Every person that comes needs to feel engaged. They need to feel a part of things. Our governance that we put together requires you, if you're going to be a member of the Ohio Partners for Cancer Control, you must be on at least one subcommittee. And in that subcommittee, the chairs are charged with making sure that person has a job to do. The other thing we did is we don't have a budget for the OPCC. Okay? There's no brick and mortar building anywhere that says, welcome to the Ohio Partners for Cancer Control. Please see the receptionist and sign in. There's nothing like that. Okay? It runs on goodwill. And so we meet at the American Cancer Society. They're just always the perfect host. And the people come. We can't buy lunch. We pass around an envelope. And people put in $5 or $6 toward pizza and salad and soft drinks. That's our exorbitant lunch. Okay? But at the end of the day, people stay. You know, they don't leave at lunchtime. They don't leave when your back's turned on the screen or anything. You know. They stay and they work. And not only is it the right thing to do, but we make them feel, again, a part of things. So you just got to do that. You also, you know, you have to be brave and be bold. I'm a very amateur historian. But I like to point out, when Washington crossed to Delaware that Christmas Eve night, we know it was a success because he surprised the enemy. He didn't know what was over there. He had no idea. He could have been arrested and hung the next day for treason, but they went. And so we have to be bold in making our moves, and don't be fearful, but always stay on offense. Okay, make them tell you no. Okay, you can't live life by permission, and so you make it bold, but keep it real. And so one of the things we told our partners too was we made sure that the goals and objectives that go into the plan were things that people are already doing. So we ask, if you're actively engaged in this activity, like our breast and cervical cancer program, our colorectal cancer program, if you're engaged in increasing physical activity in the Cleveland area, if you're working in Huff and getting women in for mammograms, put that objective in the plan. You already get paid to do that. So let's stack the deck in our favor. And at one meeting, I even had everybody doing a mantra. I do not get up in the morning to lose. I do not get up in the morning to lose. So stack the deck in your favor to win. And have those things already in there that people are getting funded to do. I'm sorry, John. Go ahead.
No, and that's a great point. And I think, that was, it was necessity was the mother invention. But the good outcome of that is, I had the colorectal goal, and it is mine. But there were a lot of people around the table that helped me a lot. And the burden was a lot less being part of OPCC. So that was the value that I got to the meetings. Aside from all I had to do was walk 20 steps to get there, was the fact that there were lots of people around the table that would take me 15 phone calls to get to. We could see them all at once. So that was really a good. So when Gary Liebheimer asked me, hey, was it a good meeting? I said, yeah. There's a lot of good people around the table, and I tell them the same thing about this meeting. So and one of the things that Robert did early on as we were introducing the cancer plan was we did celebrate early successes, and we had some speakers come in and do exactly what we're doing here. And you need to tell us when to stop. So it was an educational type of thing as well, but it also it got us motivated about celebrating little successes. So. Be flexible. One of the things we didn't want it to be a dust plan, so we had mechanisms to adapt the plan as necessary. We added one objective around folks with access to mammography for folks with disabilities, and there's a whole new part of the plan that just started 3 or 4, maybe 6 months ago. So. So we have been trying to get to make this as dynamic as possible. Can we go back to a couple of slides? Keep going backwards. No, go. Yeah. There's a couple of things I wanted to talk about. That right there. Diana Fox will tell you that is in all of our meetings. Once we start talking about process and bylaws and things like that, my eyes completely glaze over. But we did, and we did get bogged down in structure early on, and it was really spent a lot of time engaging in things that were probably necessary, but some were not necessary. But it was really a tough part of the plan. It was past that.
And you do need governance, though. That establishes your committees. It establishes how you select chairs. And right now, as it turns out, we had an election of chairs in January. It is the people from our 2 comprehensive cancer centers, which is so cool to see 2 competitors side by side at the table. But that works. Yeah. It is important to have the structure, but remember, it's a guide, not a god.
Don't dwell on it. That's right. My question. So last lesson learned, I think, is the next slide, and I apologize for having these mixed up a little bit. Was looking at walking the fine line between being as active and inclusive as possible and not having a plan that is 3,500 pages and 25 pounds. So. We want to, we absolutely want to be as inclusive as possible, but really, when those tough decisions need to be made of what's in the plan and what's out of the plan, having that communication amongst the entire group and making sure that we're doing the right things at the right time with the right people is important. So, so that was something that was, something that's necessary to walk through, and that's Robert over there working that tight line. So to see that, so. Did you have anything else to add?
Yeah, too. Marketing was mentioned earlier during another discussion. And so one of the things that we tell people is, why should I join the OPCC? What's in it for me? And I have one word for them: synergy. We can all accomplish a lot more working together than we can working alone elsewhere. Also, you will have colleagues that will write letters of support for your next grant. We can supply you data. And you are surrounded by good people that share the same values that you do, and will help you clarify objectives. You can refer to the plan. The other thing we did that I would highly recommend would be, when you write your plan, when you have your plan, make it congruent with your chronic disease plan. Make that, in Ohio, we have an Ohio chronic disease plan, but also have a state health improvement plan. So make sure that everybody's on the same page, has very similar sounding objectives, if not exactly the same objectives, so that you're not at cross purposes. And some things are just cutting edge. So when we say we want to work toward cancer equity for disparate populations, the chronic disease plan says the same thing, so the state health improvement plan. So be congruent on those things. And of course, be respectful of your funding source. Ours is the Centers for Disease Control. By golly, our top priorities in this cancer plan and our work plan is, guess what? CDC priorities. And that's exactly what they expect to see, and they should. They're the ones writing the check. So have no problem with that. But build yourself some latitude. So when John had pointed out that we want the plan to be flexible, back in 2011, we did know that there was going to be recommended screening for lung cancer. At that time, it just didn't exist. Now we know that high-risk persons, excuse me, long-time smokers should get screened for lung cancer. And so that's a different thing. So that will be in the next plan. We will look for a partner and incorporate that into the next cancer plan. But our next cancer plan will be focused on policy systems and environmental change. It will be all evidence-based or practice-based approaches and data-oriented. So where does the data take us? So we do county-by-county analyses. We look at stage of diagnosis, all those things, to make sure that we're identifying the high-risk populations. And I think
that's it. Thank you. So it will be
as
in
complex
about,
and simple as that.
Yeah. So in about 12 months, we'll be hopefully have some reciprocity and have someone from the PASLT go to Columbus, because much of what we will have, we will steal from this current plan of Pennsylvania. So we hope someone will come and speak to that group as well. Are there any questions or anything we can?
Do not hesitate to give me a call in Columbus. I'm the easiest guy to find on the 8th floor. Okay. Yeah.
Just two questions. One is, what have been some of the biggest wins for Ohio in terms of changes in how cancer is addressed for the state as a result of the plan? And how do you prevent 18 months of planning, a short period of time to implement, and you're back to planning again? How do you... Is the next cancer plan that you plan able to build on the excellence of the first one and may not take 18 months? I mean,
Short answer is yes. It will not take 18 months.
It won't take 18 months.
We're starting to work on it now. We've got our committees charged up with looking. Matter of fact, it's hard to keep them on track on what we're doing now. They're thinking ahead to January 1st, 2015. And so it is good. But no, we are building on the success. And the whole idea, the other things that we've emphasized is we're building platforms. And so we're laying a foundation for future work. So keep in mind, everybody keeps in mind that next year we'll build on what was already accomplished. What did we find out? But the biggest win that we have had in Ohio is going smoke-free in public places. And that was a long, hard-fought battle. That did not happen overnight. And you would think that it'd be a no-brainer to have smoke-free public schools on the grounds. You just think, who could possibly be against that? Lots of people. So. I know, we're getting the hook.
We're getting the hook. Okay.
You've got good people from Ohio working together, putting together good plans. How do you assure yourselves that what you come to agreement on is in fact being executed? It may sound like a rather blunt and broad question, but
it's an excellent question.
Data-driven.
Right.
It seems to me when you have a program, regardless of what it is or who is doing it, as an epidemiologist, show me the data, show me the data, show me the data. Someone may not be building that into their evaluation. I have no evaluation after all the money is spent and all the effort is made. So I'm trying to sort of reconcile how this all comes to.
Absolutely, good question. Let me summarize your question. So how do we know it's taking place?
Well, that's
the hard work that we've done. Another is the evaluation component. Okay,
Yeah.
two quick answers. I know we're running out of time here. Okay, one is we depend upon the chairs. So we have subcommittee chairs. Their job is to keep the minutes, keep track of the progress, and report back to me and also to the executive committee. So I also happen to be the administrator for the coalition. Okay, so we work hand in hand. There's two chairs, and we have a 7-member executive committee. But I get the reports back, and so do they. So that's how we know what's taking place. That's why I can say that most of our objectives are going to be met, and the ones that aren't being met was because it just wasn't funded. Okay, so we didn't achieve the funding that we thought we would. Okay, the other on the evaluation, the CDC application, this budget go-around, required us to have an evaluator. And so we had to have an evaluator on board at least 1/3 time, and we wanted to make sure that this was going to be an independent evaluator. I didn't want, if it came out to be a smashing success, which I anticipate it will be, I want to say, well, yeah, you had to work right next to Robert Indian all day long. Of course it's a success. No, I have given her total independence. We provide a place for her to sit, pencil and paper, computer, etc. The phone numbers of the executive committee and of the people on the coalition. She is conducting her own independent evaluation, and I have no idea how it's going to turn out. But that will be, did the process work? And as John pointed out in his PowerPoint, she is evaluating the plan, the coalition, and the program. And so her report is due no later than June 29, that magical date for funding with the CDC, and we'll find out how we did. The rumors I hear back is that we're doing great. But she has...
Those are just rumors.
Yeah, those are just rumors. Rumor has it, yeah. Does that answer your question okay? To some extent, that's how we're doing it.
It seems to me...
Is it perfect? No.
You control the purse strings in your agreement or contract, or you control what gets done down to that level of detail. If you don't have the money, you have to have a lot of faith, and they in turn have to
Absolutely.
buy into everything that everybody is saying.
You're right, and I think that's where
the
they...
reality.
Right.
But I think really, holding people's feet to the fire through the committee structure and having that buy-in, all along during the planning process, we said, you're going to own this part of it. You're going to, own this part of it, and getting that from affirmation all the way along does help, but it's not perfect. Right? So. Yeah.
And lastly, we celebrate successes through our newsletter. If I mentioned this, forgive me. The newsletter is named Synergy, after what it is we want to achieve. And so we put success stories into that newsletter, so everybody gets to see it. It's electronic, it's got very wide distribution, bright colors, and all that good stuff.
I just want to say thank you for the reminder. I think you made a really good point to building success. I think sometimes that we try to be so innovative or looking for those synergies that we forget to build in those success structures already there, so thank you.
Absolutely.
I love that. That's a take-home.
Sure. Right. And again, thank you for being here. Sorry.
This might be too early for your group, as you mentioned, the coming assessment, you're going to be looking at policy systems, environmental changes. But the one thing that I think will be a challenge for us, and I wonder if you have any early thoughts about this, is sort of walking the talk. So when groups go out and say that they want to promote policy systems, environmental changes, and then you go to a breakfast where they have bacon and all sorts of high-fat foods. So that whole piece I think is always really interesting. So the facilities that are smoke-free campuses, and that there are other initiatives all around the things we're trying to do, incentives from a workplace standpoint built into their incentive plan design to make sure all the screenings are, well, we know that all just general screenings don't have a copay or deductible. But those types of things that are part of it, we seem to have like an out-of-body experience sometimes when we do this as professionals.
Sometimes.
This is what we think should happen out there, and then when we think about keep getting our own house in order, we sort of just...
Sometimes you left out the alley next door where the smokers go?
Yeah, right?
Yeah.
Okay.
That's why we have the salad with the pizza. That's why we have the salad with the pizza. So.
But I think walking the talk is, walking the talk is always a goal, and human frailties being what they are, and living in a free society, you're not going to regulate everything. So yeah,
I'm saying as leaders, I'm kind of in terms of early successes, that could be something that we
Absolutely.
hopefully have control over.
Yeah.
and be able to be an early win. where if this is what we're speaking and asking others to do, shouldn't it be something that we
Right.
roll on?
Great idea.
Right. Great idea.
Well, thank
Yeah.
you very much.
Thank you.
We'll be here the rest of the day. So.